Hi everyone. My name is Xinrui. Sorry that I cannot be with everyone in the room physically because of my visa issue, and I really appreciate the opportunity to present remotely about our work, an empirical study on KDIGO-Defined Acute Kidney Injury Prediction in the Intensive Care Unit. This work wouldn't have been made possible without my excellent collaborators from ETH Zurich and the Max Planck Institute of Biochemistry in Germany. We also have great clinical knowledge support from two intensivists from the University Hospital Bern in Switzerland and Auckland City Hospital in New Zealand. To begin with, I would like to briefly introduce the background of our work and why we are interested in predicting acute kidney injury, also known as AKI. The kidney is one of the important organs required to maintain homeostasis in the human body. Acute kidney injury affects all systems of the body. KDIGO is a global nonprofit organization that develops and implements evidence-based clinical practice guidelines for kidney disease. Its 2012 AKI guideline has suggested that acute kidney injury should be staged according to the severity outlined in this table. Urine output and serum creatinine are the two important biomarkers used to define and stage AKI. Patients with AKI in which structural damage does not occur may fully recover. AKI with structural damage causing irreversible nephron loss frequently lasts longer than 7 days, which is classified as acute kidney disease, and the irreversible nephron loss precludes restoration of the baseline glomerular filtration rate, resulting in chronic kidney disease or persistent kidney failure. Kidney lifespan depends on the individual endowment with nephrons. The red line and the blue shading show the average and percentiles of the decline of nephron number and glomerular filtration rate with age. The average kidney lifespan exceeds the human average lifespan. Each irreversible nephron loss related to a kidney episode reduces kidney lifespan. The consequences on kidney lifespan may be little for people with high nephron endowment. However, the kidney lifespan is shortened significantly for people with an average or low nephron endowment. The worst case could be that kidney life ends directly after the AKI episode. AKI at an older age has a more immediate effect on the remaining kidney lifespan than AKI at a younger age. So prevention and early detection of AKI are essential. However, management of AKI is often not optimal. An audit in the UK in 2009 found that more than 50% of the patients were managed poorly, and 43 of the AKI cases were recognized late or not at all. Promising recent work on modeling adverse events from electronic health records suggests that the incorporation of machine learning may enable the early prediction of AKI. A work in 2018 by Mohammad Low and his co-authors used gradient boosting decision tree to predict AKI. However, it failed to demonstrate adequate clinically applicable predictive performance. Another work in 2019 by Pan and his co-authors used recurrent neural networks for predicting AKI. However, they focused on predictions across a short time horizon, which leaves little time for clinical assessment and intervention. The work by Tomasev and his co-authors from DeepMind developed a clinically applicable model that outputs a probability of AKI occurring at any stage of severity within the next 48 hours. However, their models were trained on patients from the US Department of Veteran Affairs healthcare system, which is not representative of the global population because about 94% of the population is male. And another caveat is that they only use serum creatinine for labeling AKI because urine output was unavailable in the dataset. The work by Cao and her and her co-author in 2022 is majorly based on the work by Tomasev's work, and try to make their model more generalizable by training on more gender-balanced data. Nevertheless, the work by Cao still did not resolve the incomplete AKI definition issue. And our work benchmarks the performance of different machine learning models in future AKI prediction in various settings, which I will cover later. We also use the full KDIGO AKI definition based on both serum creatinine and urine output. Our prediction task is whether patient will develop any stage of AKI in the next 48 hours. And for evaluating generalizability, we use two datasets collected from Switzerland and the USA. For HERIT data collected from Switzerland, we use temporal splitting, where the test set consists of only data from patients admitted to the ICU later than those in the training and validation sets. Such data splitting setup help evaluating whether models generalize well into the future. However, we could not perform the same temporal splitting on MIMIC dataset because the original time information was no longer available in MIMIC. Therefore, we just perform random splitting on MIMIC. And this is what we do for data preprocessing. First, we impute missing values in the data. However, not all missing values are imputed. For each patient, we only impute missing values between her first and last heart rate measurement, which we use as a proxy for the period when the patient actually stayed in the ICU. Additionally, missing values within the so-called active period since the last measurement were imputed using the forward-fitting strategy. The active period are variable-specific and were defined and reviewed by the intensivist based on their clinical knowledge. Missing values beyond the active period were left as missing. After imputation, we then construct features for inputting the machine learning models. Three types of features were constructed. The current value features simply are the variable values at time t. The multi-scale history features are the summary statistics over 4 different horizons in the past. And the summary statistics are the median, the standard deviation, and the trend summary. The measurement history features encode the overall measurement frequency and time since the last actual measurement at time t for each variable. In our benchmark, 4 gradient boosting decision tree variants were explored. GBDT snapshot takes only the current value feature as input. GBDT history takes the current value, multi-scale history, and the measurement history features as input. And we also constructed time-stacked gradient boosting decision trees, where each gradient boosting decision tree is specialized for 1 hour period during the stay. So for ICU stays longer than 48 hours, then only 1 gradient boosting decision tree is trained for the period after 48 hours into ICU. The time stack scheme is motivated by our initial observation of the high relevance of the time since admission feature to the prediction task. In this way, the prediction model is conditioned on properties of different phases of the ICU stay. As the final step, all gradient boosting decision trees are post hoc calibrated by isotonic regression using the validation set to encourage smooth prediction score trajectories. Time-stacked GBDT can be combined with different types of inputs, resulting in 2 variants, namely time-stacked GBDT snapshot and time-stacked GBDT history. We also evaluate the performance of the LSTM model proposed in Tomasev's work. To compare model performance between different models in an unbiased way, each model is trained on the same set of variables. GBDT selects the top relevant variables by assessing sharp importance and its contribution to the model performance improvement. LSTM selects the top relevant variables using the permutation variable importance measures. The union of the important variables yields 28 variables, which is the set of variables all models are trained on. We use event-based precision recall curve and alarm load to evaluate performance of machine learning models. The event-based precision recall curve was proposed in our previous work. So alarm is raised when the prediction score passes a threshold, and within 8 hours after an alarm, no other alarms are raised. This silencing strategy is adopted to reduce alarm fatigue for the clinicians. And when the patient just recovers from an AKI episode, the prediction scores may still stay high, therefore no alarm are raised within 12 hours after recovery. An alarm is considered to be a true alarm when there's at least one AKI episode within the next 48 hours and false otherwise. An AKI episode event is considered captured when there's at least one alarm 48 hours before the event, otherwise it is considered missed. For each threshold, we can then compute a pair of alarm precision and event recall, and then construct an event-based precision recall curve. The second metric we use is the alarm load. This measures how many alarms clinician would expect from a patient who is likely to have AKI and how many false alarms they will expect from a patient who does not exhibit AKI. All alarms raised in a patient calendar day without any AKI event in the next 2 days, i.e. 48 hours, are false alarm. Alarm raised in a calendar day with at least one AKI event in the next 2 days are true alarms with very few exceptions. We assess models by the average number of alarms in both calendar day types. These two metrics are much more relevant to the clinical applicability than AU-ROC and time point-based precision recall. Now I will present you our findings in the benchmark work. First, we compare the full KDIGO definition with a serine creatinine-only definition used in Tomasev's work. We observed that the full KDIGO definition results in a much higher prevalence of AKI events in the HERIT dataset. This result shows that the serine creatinine-only definition is insufficient in the ICU setting. And all the following results from now on are based on the full KDIGO definition. We then compare different machine learning models. We observe while all GBDT variants outperform LSTM in terms of area under the event-based precision recall curve, time-stacked GBDT snapshot is the best performing among all. And when we zoom in to a point where the event recall is 80%, so the second row in the table, the alarm precision of LSTM is as good as those of the time-stacked GBDT variant. Another aspect we look at is the number of false alarms per patient per day, and time-stacked GBDT snapshot yields the lowest number of false alarms. A good AKI predictor should have robust performance across different healthcare systems. So here we compare the performance of the best performing GBDT variant and LSTM on data collected from Switzerland and the USA, respectively. Time-stacked GBDT consistently performed better than LSTM in both datasets and both metrics. We investigated the effect of reducing training set size on model performance because data scarcity often hampered the development and deployment of clinical machine learning models in practical settings. As we can see in this figure, GBDT snapshot outperforms GBDT history, which outperformed the LSTM model when more than 5% of the full training set is used for training. It is also noteworthy that the area under the event-based precision recall curve performance loss is relatively minor, even at extremely small training set sizes, which corresponds to only 40 patients at 0.1% of the training set size. We then evaluate gender fairness of the model in two different ways. First, we analyze the performance of each model on each subcohort in the test set. That's the figure on the very left. In addition, we evaluate the ability of the model to transfer from one gender to the other. Neither of the model exhibit issues with model transfer between genders. So that's the two figures on the right. However, the LSTM model exhibits slightly larger variance in the different splits. Both models also show fair performance on most subcohort divided by diagnostic category and age, with the exception of patients in the age group from 16 to 30, which exhibit reduced performance. And the GBDT model performed better in most of the investigated subcohorts. And when we analyze the feature importance for different models, we found that GBDT-based models show the strongest dependency on the time since the emission feature, which could explain the success of the time stacking strategy. And enteral feeding and weight come as equally important feature in the second place for the GBDT-based model. LSTM models show the strongest reliance on dialysis, which intuitively makes sense, as dialysis is commonly associated with various stages of AKI. Enteral feeding, urine output, C-reactive protein, ATCO2, and creatinine were also considered important to the LSTM model. AKI is a treatable condition, and fluid or furosemide treatment can be used to manage the condition. So to explore their effect on our prediction, we investigated the interplay of treatments and predictive performance of the GBDT model. This table shows that the prevalence of AKI among patients with any of the two treatments is elevated. Patients with any of these two treatments show a 2.1% increase in the false alarm rate, suggesting a slight loss in prediction precision in presence of AKI treatments. So to conclude, we observe a significant number of missing AKI events when neglecting urine information. We perform an extensive benchmark of two state-of-the-art machine learning models, GBDT and LSTM, where a GBDT variant exhibits better performance. Both models have shown robust performance on the limited training data, different subcohorts, and different healthcare system settings. And thank you all for listening. And does anyone have any questions?
Do you have one slide that has the performance of the model?
Yeah, sure. I can present this. So here in this slide, we compare different machine learning models, and then we observe all the GBDT variants outperform LSTM in terms of the area under the event-based precision recall curve. And time stack GBDT snapshot is the best performing among all. And also when we look at a specific recall, we found that LSTM also have like as good alarm precision as the time stack GBDT variants. So another aspect we look at is the number of false alarm per patient per day, and then time stack GBDT yields the lowest number of false alarm. And this is a comparison of the different machine learning model across different healthcare systems from Switzerland and USA. The conclusion is here is like both model have like a robust performance across different healthcare systems, while time stack GBDT snapshots still consistently perform better than the LSTM in both metrics like event-based AUPRC and alarm load. And I mean, I have many more results, but that's like the two major results I could show. The others are just like results under different settings, like limited training data scheme, and then fairness analysis in gender groups and diagnostic group, age group, and feature importance analysis. And finally, it's like a treatment analysis. I can also put the slides to the link of this talk on the platform. I hope everybody can download it and see it for themselves.
Okay, sounds great. Thank you so much.